A huge welcome to you all, and thank you for coming along to our webinar today, which is with the topic being science communication in a pandemic. And it's my absolute pleasure to be hosting this webinar for you all today and acting as moderator and chair for this opening event of the second World Evidence-Based Healthcare Day. The next 48 hours are going to be an incredible amount of fun for us all, as there's so many webinars, events, Twitter sessions, social media activities, and everything else that's going on. So thank you all for taking time out of your busy day today to come along, and you are in for a real treat because we have a fantastic array of speakers coming up. So strap yourselves in and get ready to enjoy the next 90 minutes as we discuss science communication in a pandemic. Now, by means of introduction and also just putting out my disclosures as well, my name is Zachary Munn, and I'm an associate professor at the University of Adelaide and the director of evidence-based healthcare research at JBI. I'm also the chair of a Guidelines International Network and a director for a grade centre here at JBI as well. So it's a pleasure to have you all here today. Now, we are here in Adelaide, at least I am here in Adelaide. I know we've got people joining us from all over the globe today, but here I am at JBI headquarters in Adelaide, and at the moment we are hosting this webinar from the lands of the Kaurna people. And I'd just like to acknowledge that the Kaurna people are the tradition custodians of this land, of the Adelaide Plains. And I'd also like to acknowledge the traditional custodians of the various lands which you are all on and working on today. And I'd also like to acknowledge any Aboriginal and Torres Strait Islander people who are participating in this webinar today. And also just like to say that the land we're on right now always was and always will be Aboriginal land. And particularly as we share this knowledge on World Evidence-Based Healthcare Day, may we pay our respects to elders, both past, present and emerging, and their knowledge and experiences as well, which we can all learn from. Now, some of you may also be on social media, and we would love to see you tweet about this webinar on social media as well. And you can do this by using the hashtag World EBHC Day, or the hashtag evidence first. And if you aren't already following the Twitter World Evidence-Based Healthcare Day account, you can see our handle on the screen here at World Evidence-Based Healthcare Day. So what are we talking about today? This might be the first time you've actually heard of World Evidence-Based Healthcare Day, and you may be wondering, what is this all about? Well, this is actually the second World Evidence-Based Healthcare Day after a very successful launch of the day last year. And the aim of the day is to really shine a spotlight on the need to use better evidence to inform healthcare policy, practice, and decision-making to improve health outcomes globally. Now, this year, for the 2021 campaign, we are focusing on the role of evidence in an infodemic. So we are trying to identify how we deal with evidence in an infodemic and make sure we are still promoting access to trustworthy, evidence-informed health information, which is some of what we'll be discussing today. And I'd also like to acknowledge all of the official partners who are working together to bring us all World Evidence-Based Healthcare Day. As you can see listed here on the screen, we have 8 official partners from really all across the globe who work very hard to bring World Evidence-Based Healthcare Day to us all. And I would also like to acknowledge our principal sponsor for World Evidence-Based Healthcare Day, which is Wolters Kluwer Health, and thank you for your support. Right, so all of the partners, all of the official partners put their heads together and actually nominated speakers for today's session once we worked out our topic, science communication in a pandemic. So we are really, really lucky to have this wonderful group of speakers lined up for us all today, presenting on science communication in a pandemic from many different perspectives as well. Our presenters will be taking us through a journey through different aspects of science communication today. With Johanna, starting with discussing who is accessing evidence, why and how, followed on by Jo, who will be talking about how we can look at the challenges presented by the pandemic in terms of information and evidence and what happens to information and evidence within a pandemic. And then Jack will be going on to the need for different structures to successfully communicate evidence. And Nasreen will be following that up with discussing different intermediaries, opinion leaders, and voices in pandemic communication. After that, after these formal presentations from these four speakers, we'll be having a very open Q&A and panel discussion. And we're very lucky to have Jane Cowell and Janny Wald also joining us for this discussion, where we'll be answering all of your questions about science communication in a pandemic. Now, it might be useful, although it sounds like there's a lot of researchers and academics on the line already. It might be useful by doing some scene setting and also explaining some of the definitions for the terms you might hear today from our presenters. Starting off, of course, with science communication. And what is science communication? Well, science communication is a practice of communicating, disseminating, informing, educating, or raising awareness of science-related topics and results of research to a general or non-expert audience. So we're talking about really communicating evidence and science to the public. Now, one new term which you might not have heard before is infodemic, and this was coined by the WHO at the start of the pandemic that we're all in. And this definition from the WHO is that an infodemic is too much information, including false or misleading information, in digital and physical environments during a disease outbreak. It causes confusion and risk-taking behaviours that can harm health. And it also leads to mistrust in health authorities and undermines a public health response. And this is something we've seen to a very grand scale during this pandemic, where there is just so much information out there and a lot of it being false or misleading. And sometimes it's hard for people to know who they can trust in terms of the evidence. And this can sometimes undermine the public health response. Now, we've used the term evidence a little bit as well. And when we use evidence, this is a very broad term, but what we're talking about is information on which a decision, actions, or guidance is based. And it can come from a range of studies, including randomized controlled trials and other types of studies as well. And data, when we talk about data, this is the information that we collect through research. You might also hear the term systematic review throughout the day, and I know Jo will talk a little bit more about systematic reviews later, but really systematic reviews synthesize and collate and appraise all of the evidence that is out there, and then create a summary of all of that evidence and all of those studies, which can hopefully make some conclusions and some implications from that systematic review. And when we talk about trustworthy evidence, we're talking about evidence that we can actually trust or have confidence that the results of this evidence or the recommendations or the guidance that is being produced is actually something that we can trust. And hopefully it's been based on rigorous standards for research and guidance development. And finally, just wanting to define what we mean by end user, which is also a term we might use throughout this session. And really an end user is anyone who's looking for information or evidence. And this might be in different roles. It might be in a role of a patient, it might be in a role of a consumer, a citizen, or a stakeholder. So it could be anyone who is going to use that evidence in some way. And then, of course, today we're talking largely about communication to patients and the public. And obviously, these are people who have experiences of a disease, condition, or service, their family members or carers, and it also just may refer to members of society interested in health and social care services. Okay, right, so there's some of the terms that you might hear throughout this presentation today, and hopefully help set the scene for what we're going to cover also. But without further ado, I think it's time to really get into hearing from the experts on this topic. And I'm really pleased to firstly announce our first speaker, who is Johanna Hulme, who is the Associate Director of Content Transformation at NICE. She is a pharmacist who is transforming content at the National Institute for Clinical Excellence in the UK, and is developing useful, usable, and used content aligned to people's needs in the health and care sector. Johanna has worked in guideline development for many years and has helped set up many innovative guideline programs at NICE. And she'll be telling us all about the importance of determining who is accessing evidence, why and how. And I'd like to hand over to you, Johanna, to start with our first formal presentation.
Great, thanks, Zach. Just share my screen. So thanks for the introduction. You've already explained who I am and my background, so that's really helpful. I work at NICE, as Zach has said, and NICE is an organisation in England, and our role is to produce evidence-based guidance and advice for health, public health and social care. The work that we've been doing is really exciting as part of a transformation. And as part of this presentation, I just wanted to kind of capture the process that we've been going through as part of this innovative work. So I'm going to cover who our users are, thinking about user typologies, job stories, the ways people read and access our content, designing content user needs and structuring our content. And obviously content wasn't one of the definitions that Zach had up on the screen just a minute ago, but when we talk about content, we talk about all the information that NICE produces in this presentation. So in terms of what we've been doing, we've been working on a content transformation, so trying to understand a bit more about how people use and access our information. And in part, it's because we have a new strategy. So again, we're trying to move our content into a more digitally focused area. In terms of what we've been looking at, we've been trying to understand who our audiences are more broadly. So who are the kind of like the stakeholders and organisations that may take our content and reuse it. We've also been looking more at who our individual users are of our content in terms of the tasks and the behaviours that they use rather than the specific job roles. And I'll talk more about that in my presentation. And then thinking about how we can present the content for those user needs. So as part of our work, we've identified 4 user typologies, which are based on standards in industry that we've applied to our particular needs. So the different typologies have different behaviours, as I've mentioned, and users may move between different typologies depending on the scenario or the situation that they're in. So we've identified, first of all, grab and go users. So these people are people who are looking for a specific answer to a question. They tend to want quick, simple and easy to access information. So they tend to access the information and then leave the website quite quickly. In terms of topic foragers, they look for an initial topic and have a look and see what NICE has available and trying to explore it a little bit more. They want to have clear navigation for the content to reassure themselves that they found everything that might be said on that particular area. Engaged explorers, these are people who actively engage with all levels of our content on a specific topic. So they want easy navigation through different layers of information. So if they want more detail around the evidence that sits behind a recommendation, for example, they can find that easily. And then finally, update seekers. These are people who are wanting to know what's changed in practice, what's the latest new news, and they tend to want a summary of latest updates. Now, we don't want to try and put people in boxes, and ideally people will move between the different scenarios, as I've said, and quite often we've found from our research that people may start off by fitting into a grab and go user, but actually when they get into the website, they think, oh, actually, I want to understand a little bit more about this particular topic or what's new. So they do move between different areas. And these typologies, again, they're not set in stone. This is what we've found from our current research. And as we understand more about our users and what they require, these are likely to change, or there might be new categories that are created. So from the typologies, we then started looking at job stories. So again, this is an approach where we can identify particular scenarios or tasks that these particular typologies are looking to do. And the framework that we've used for this is situation, motivation, outcome. So when I need to, so that I can. And again, we've created lots of these for different types of content to identify a bank of user needs, or job stories, should I say. So for grab and go, this might be when I am checking nurses are following best practice, I need to use NICE compliance tool for best practice so that I can identify service delivery improvement ideas. So again, it's kind of putting a spin on what's happening in real life and aligning that with the guidance development processes. From the job stories, we've also looked at research to understand what people are actually doing when they access our website. So here are some screenshots of a NICE guideline. This is for somebody who's a kind of topic forager who wants to get into the detail. So you can see here on the image here, the blobs are where somebody is looking or clicking when they've used their mouse, and this is recorded. So the bigger circles indicate where they've spent more time on that particular area. And you can see here there's a general F shape, which indicates kind of how people access digital content, which is different from a book, for example, or a long PDF document. So they will skim, so they will start reading and they will skim and try and find the information that they require. If you move on to the next diagram here, you can see that people are generally looking at the headings to try and get the information that they want, but they are looking at the whole guideline. And then this here is a screenshot of two separate screenshots because the guideline's so long. But again, you can see throughout, as an engaged explorer, somebody is wanting to get into all of the information in the guideline. Whereas for a grab and go user, you might see more of just the kind of the high level, wanting to get the information quickly and then moving along. So with all that in mind, we then started to think about how we would create or design our content. And it's not just about words. We want to know what our users are trying to do with the content, and then think about how we can structure and present it in the right way or format for them. We need to understand the data behind it and put the information that people need front and center. We need to understand the importance of subheadings so that we can tell the story and allow them to skim the page, as you've just seen in the eye tracking. And it's about getting the navigation and the journey right. But there's lots more than that. And obviously, as an organisation who produces guideline recommendations, we're starting to explore how we can get this understanding of user needs and job stories involved in the guidance development earlier on. And Sarah Winters, here is at Content Design London, who are experts in content design, have said without knowing the actual user need, you can't really structure information in a user-centered way. So you're missing an important part of the relationship with your audience. So in terms of what our user needs, these are needs that express people's goals, values, or aspirations. They are the things people need from a product or service or content to do something. So we need to make sure that we're presenting our information in a way that people need and understand. We need to learn about users' needs by asking them and not making assumptions. And I think we're probably all guilty of that we think we know what a GP or a patient may require in terms of their information, but actually we need to just ask them. And we need to help users by presenting evidence in a way that can help them in their decision making, which is particularly important for shared decision making. So with all of this, we've also started to think about how we can present our content and structure it in a way that allows us to identify the types of information that these different typologies need. And this diagram really just shows that different typologies will have different requirements and needs. They may want a high level summary, but they want to drill into different layers. And the different shapes indicate that some typologies may require more in-depth information and want to go into more of the layers. and others want different types of layers. So they might have the same level of information, but they want the different types. So in summary, creating our content for our users, we need to ask them what they need. We also need to test prototypes and ideas along the way. So instead of creating all of our information out over a 2-year period and then saying, ta-da, here you go, here's the guideline, we need to kind of check in along the way and identify if the presentation and the content is fitting what they require. We need to take account of different user needs because everyone is individual, but there are broad categories of where we can help people in their requirements. We need to build the content on job stories and the tasks that people are doing to help them in their decision making, and structure it in a way that allows us flexibility in terms of the output. In bringing different types of content together in a way that responds to our user needs, we need to make sure that everything is fit for purpose. It's an iterative process and it's continually evolving. So even though we might have something right today, we need to think about the external environment and how that changes and respond to that accordingly. And the main thing is that we need to understand what our users need and not what we think they need. So, thank you for listening.
Fantastic. Thank you, Johanna. That was a really, really interesting presentation. And I love the terminology you use, the grab and go, the topic foragers, the engaged explorers, and so on. That's really engaging. Thank you. I was wondering, do you think your typology of users, do you think that would apply more generally to, I guess, all health information and evidence? So maybe across other guidelines from other groups, but also across things like Wikimedia and Wikipedia, and news sites and everything else?
Yeah, potentially. I mean, the typologies are from an industry standard and we just applied them for our requirements. So, and I think as you understand more about them and asking people what they actually need, it does show that there are broad categories. And I think as a previous guideline developer, I've sat on the other side of the fence and with a committee, and you kind of get in that bubble of guideline development, kind of thinking, well, I know what everybody wants. They want this, they want that. But actually, we need to ask them, and I think that would apply to any content that you produce, whether it's guidelines or it's just advice or implementation support slides, whatever.
So that's really, really, really interesting. So do you think, from a guideline developer, and you've highlighted that we need to ask what people want and what they need, but has there been any sort of contradictions or conflicts in terms of what the guideline developers thought people want, and then actually seeing from your studies what people actually want and need?
So at the moment, we're still kind of very early on in the project, and we do need to link it more with guidance development. But I think from our own experiences, sometimes when guidance is published, because it's taken so long in the process, the external environment has changed. And actually, by taking this approach, it allows us to respond and adapt more quickly, particularly where you've got a fast evidence base, particularly like with COVID. It's important to try and adapt and respond quickly to those requirements.
Yeah, definitely. Fantastic. Thank you, Joanna. That was a really fantastic presentation. All right, well, we go straight on to our next speaker now, and I'm very pleased to introduce Professor Jo Thompson-Coon, who is a professor of evidence synthesis and health policy. And since 2009, Jo has led the PENARC evidence synthesis team, where she is involved in producing systematic reviews and evidence syntheses to inform locally relevant evidence-based practice. And evidence synthesis nut, just like myself, it seems. And her team also plays an integral role in the identification and prioritisation of research projects for development within the Southwest Peninsula in England. And it's an absolute pleasure to have Jo here talking more about what information and evidence is available in an infodemic. So, Jo, I will hand over to you now.
So as Zach said, I am a professor of evidence synthesis and health policy at the University of Exeter. but I'm also editor and co-chair of the Ageing Coordinating Group within Campbell, and it's the Campbell collaboration that I'm representing today. I'm delighted to be able to represent them in this session. I'm also one of the co-directors of the Cochrane Campbell Global Ageing Partnership. So I have no conflict of interest. I'm funded by the National Institute for Health Research, Applied Research Collaboration, Southwest Peninsula, and the views expressed in this presentation are my own. So if you're not familiar with the Campbell collaboration, it's an international network producing high quality, transparent and policy relevant systematic reviews and other evidence syntheses in the social sectors. And the collaboration is organised as a series of coordinating groups as shown in the slide. So you can see that there's a really wide range of different topic interests within the collaboration. My plan for the next 10 minutes is I'm first of all going to talk about some of the challenges of using trustworthy evidence to guide decision making in the pandemic. I'm then going to pause and we're going to have a poll and ask you what is your approach to reading a systematic review. And then I'll reflect on the challenges of finding trustworthy evidence to guide decision making in an infodemic, drawing on some work that we've been doing in Exeter. And I'll finish by highlighting some of the positive developments that will no doubt help us to deal more effectively with the next health emergency. So I imagine most people at this event would agree that it's important that health and public policy decisions are based on reliable, comprehensive and rigorous evidence, and that systematic reviews and guidelines which identify and bring together all the relevant high quality studies that can help to answer a question are an essential element of that process. An added benefit of systematic reviews is that they should make sense of the balance of evidence when individual studies conflict. And we've seen examples from the pandemic of where the reliance on an individual study rather than an evidence synthesis has led to misinformed decisions, which in turn lead to public harm and mistrust. But producing relevant and timely systematic reviews to inform decision making during a pandemic is challenging. Because it takes time to produce a robust systematic review. The pace and volume of new research being produced has been overwhelming, and the context is continually changing. And the findings of systematic reviews are therefore often uncertain, and this uncertainty is really difficult to communicate effectively, and that has been challenging for evidence users, from policy and decision makers to members of the public. The international evidence synthesis organisations such as Campbell, Cochrane, JBI have been working to overcome some of these challenges, for example, by developing methods for rapid reviews, working more closely with evidence users to focus efforts on priority research questions, and highlighting existing relevant reviews. And in Campbell, we realised that the Campbell Library already contained a number of systematic reviews useful to inform the social and economic response to COVID-19, and produced a virtual issue of 50 relevant systematic reviews and a series of blogs to accompany it. And you can see from this diagram that the virtual issue brings together reviews on a really wide range of topics, some which had immediate relevance, for example, how to promote hand washing or distribute cash in emergency settings, some that offer guidance to support vulnerable populations, including older people. And as economies reopen, Campbell reviews offer ideas on how best to get people back to work, including labour activation measures such as youth employment. But not all systematic reviews are produced by the likes of Cochrane and Campbell and JBI. And in fact, the majority of systematic reviews produced during the pandemic were not. Epistemonicus, which is a collaborative multilingual database of health evidence and the largest source of systematic reviews relevant for health decision making, now contains more than 5,700 systematic reviews related to COVID-19. So before we go any further, I'd like to ask you, what is your approach to reading a systematic review? And I think Zach is going to do the poll. So I have here some options, and there might be others. So I've tried to think of lots of different ways how you might approach reading a systematic review. If your approach varies, perhaps just choose the approach you've used most recently. And I think we'll come back to look at the results later on, but Zach's going to let me know when most people have had a go.
Yeah, it looks like we're getting quite a few people putting in their answer now, which is great. Spread out across the different options, and there's a few people who don't read systematic reviews at all, of course, as well. And
Yes.
It's great that there's some members of the public here today who might not know so much about systematic reviews. So we're up to 65% of people have voted now. And there's still a couple more coming in. If you could I'll just give it a few more seconds so you can quickly choose your option. It looks like those votes have stopped coming in, Jo. So I might share those results if you like.
Fabulous. And if you have another way of reading systematic reviews, let me know. So okay, we'll come back to those if that's okay, Zach. But I can see we do have a range of different ways showing on the poll, which is really good. Fantastic. Okay, so I'm now going to talk for just a couple of minutes about a meta-research study that we undertook last year to explore the characteristics, quality and volume of the first 5 months of the COVID-19 evidence synthesis infodemic. So this is work that was conducted in Exeter. And we included 280 systematic reviews. These were reported as a systematic review, a rapid review, an overview, a meta-analysis, or a qualitative evidence synthesis in the title or abstract, which addressed a research question relating to COVID-19. And 88 of these met the more rigorous criteria, which are shown at stage 2 there. So this slide shows the percentage of included reviews that met the rigorous criteria needed to progress to stage 2. And you can see that for some of the elements, many of the included reviews met the criteria. For example, setting out a clear research question, reporting search sources, but far fewer included a reproducible search strategy, described the synthesis plans, or reported critical appraisal of the included studies. We also observed, as of others, that the pace of publication of systematic reviews about COVID was extremely high, more than 2 published per day at the start of the period, increasing to 4 per day by the last month of the analysis. And bear in mind, this is like the first sort of 5 or 6 months of the pandemic. Over 70% were reported as being conducted within 3 weeks, and perhaps more worryingly, more than 50% were published within 3 weeks of submission. And whilst we can imagine that people were working hard to get the answers that were needed by decision makers and to make them available to others, this fast pace must have implications on the time dedicated to thought and interpretation, both at the conduct and at the peer review stage. And another implication of the fast pace was that there was considerable overlap in topics, with multiple reviews being published at the same time on similar topics. So this slide shows the number of citations for the top 10 most cited reviews according to Web of Science, the name of the journal, the impact factor of the journal, and the quality of the review as assessed using the AmStar2 tool, where CL is critically low and L is low. So these are massive numbers. Most of us can only dream of a paper being cited more than 800 times within the first year of publication. And yet the most highly cited review was rated as critically low in quality on AmStar2. And that if for those not familiar with AmStar2, that means that the findings should not be relied upon to provide an accurate and comprehensive summary of the evidence. So if we think back to the results in the poll, very nice to see that so many people were looking at the methods. That was their first port of call when they read a systematic review. But I hope this goes some way to highlight that not all systematic reviews are equal, and that some of the factors that we might use to judge the trustworthiness of evidence, such as being reported as a systematic review, or the name of the journal, or the impact factor of the journal, might not be the right thing to do, and therefore the importance of not only reading but critically appraising the method section of a systematic review before we use it to guide decision making. I think also, hopefully, this helps to highlight the importance that the role that we all have in helping to improve the trustworthiness of evidence to guide decision making. So that includes the people kind of doing the reviews, but also peer reviewers, journal editors, funders, and the evidence users who, should be able to trust the evidence that the research community is producing. So I'd just like to end on a positive note by highlighting some of the innovations that we've seen within the evidence synthesis community over the course of the pandemic that will no doubt help us to deal more effectively with the next health emergency. Methods for producing rapid and/or living systematic reviews and guidelines are continuing to evolve. We've seen a really increased appetite for the sharing of resources and collaborative working. We've seen the development of 2-week systematic reviews, which are full systematic reviews done following all the normal systematic review processes, but very much quicker, using experienced teams and automation tools. COVID End, which is a network of more than 50 of the world's leading evidence synthesis, technology assessment and guideline development groups around the world, which is helping to support decision making and reduce duplication. The Epicenter Living Map of COVID-19 evidence, which uses novel, efficient automation tools in place of repeated searching for evidence. And so these resources, perhaps at the moment specific to COVID, but we've allowed us to develop methods which could be used for future pandemics. And then the last thing is the Cochrane Convenes event, which was held last week in collaboration with the WHO, which the organisers hope will be the start of a conversation about what we need to do to improve the evidence response to future global health emergencies. Thank you.
Fantastic. Thank you, Jo, for sharing that all with us. A really, really fantastic presentation. And thank you, Jo, for mentioning as well and investigating the quality of systematic reviews that have been published in this space related to the pandemic, and particularly the fact that not all systematic reviews are created equal. And there are some studies, let's say, that are masquerading as systematic reviews, but they actually haven't followed trustworthy methods. What do you think we can do about this, and how can we help people, end users, patients, the public, distinguish between high quality systematic reviews compared to those studies which are claiming to be systematic reviews but haven't been particularly systematic in their methods?
So, I mean, I guess it's, I think we all need to get better at being able to appraise the quality of systematic reviews. But as I said in the thing, I think we all have a role. So research, we have great guidance on how to produce systematic reviews, and yet a lot of people don't use it. Peer reviewers have guidance on how to peer review systematic reviews, and yet many of them don't use it. Journal editors enforce or encourage the use of reporting guidelines, and then don't enforce their use. Funders, they could be helping by requiring more robust methods. I mean, I guess within COVID, a lot of the reviews that were done were unfunded, but everything has an opportunity cost. So, and evidence users could be demanding that that the evidence that is produced is more trustworthy, more robust.
Definitely, really practical points. Thank you, Jo, for sharing. Something that really ruffles my feathers. These reviews which are done such poor quality when we spend so much of our time promoting them as, you know, the be all and end all of evidence or at the top of the evidence hierarchy, and yet we see so many poorly done. But thank you for shining a spotlight on this issue, really important issue, and providing some practical advice. Really great. Thank you again, Jo. We'll be hearing more from Jo in our panel coming up, but we better keep moving on. And next to speak, we have Jack Nunn. So Jack is the founder and director of the education charity Science for All. And this charity works to involve people in doing research by building partnerships between the public and researchers. This also includes creating standardized ways of reporting data about initiatives. I'm really looking forward to hearing from Jack, as his particular research area is in creating and evaluating equitable and ethical ways for people to get involved in all aspects of research and science, including public health, evidence synthesis, and environmental research. So fantastic to have Jack here with us. And Jack, I will hand over to you.
Thank you very much. I'm just going to share the screen. Fantastic. Well, hi everybody, good evening. And just first of all, I want to apologize for my hair. I am based in Melbourne. We haven't been able to see hairdressers for weeks, so I got my wife to cut my hair. We did look up evidence-informed methods of hair dressing, but all I could find was fringe science. So now I've heard that collective groan in all of your minds. I just want to start by saying an expert is in the eye of the beholder. There are many people speaking today who I consider to be experts in the area of evidence, and I do not count myself among them. My expertise is in getting people, public researchers to work together. But I think it's important to remember this quote from a wider perspective. Everyone in the world looks up to different people as experts in certain areas. Parents, friends, teachers, researchers, medical professionals, faith leaders, and maybe even elected representatives, depending on who has been elected. I'm speaking today from my own perspective, not on behalf of any organization I work with or am affiliated with. And I have created an accompanying resource with references, and I've tweeted the link to that. I'm not going to talk much about who I am because you just heard about that. But I do sit on the Cochrane Council, and I also do work for the Australian Federal Department of Health Medical Services Advisory Committee. So I'm looking at evidence to help make decisions about health technology from the public perspective. What do we mean by communication? I think it's important to get into this word. The roots have meanings which include sharing, making something common. Information saves lives, the right information at the right time in the right place, at the right level, in the right language. Are we doing this with important research data, with all research findings? I'll return to this question. The important thing to say about communication is it is a two-way process, and the previous speakers have touched on this. When I did some work for the Australian Department of Health on communicating health information, many experts talk of health literacy. I don't find this a helpful term. I find it a deficit model, which implies that experts know everything, or certainly more, and it's a matter of how well everyone else can follow. For me, that's around the wrong way. I think it's better to ask how communication literate are experts, and can we have evidence-informed ways of communicating? And I'll be coming to that. So it's really important to make sure communication is two-way, and this is especially important when working with people who are at greater risk of exploitation in society, whether it's the poorer people or, for example, when working with Indigenous peoples. And when I was working with Aboriginal people in Australia on co-designing a research protocol for genomics, it was really important for me to remember the historical and contemporary experiences of systemic racism in Australia, and how this might affect their trust of experts or researchers. And that's a really important thing to remember when you're coming into a community or speaking from a place that you consider expertise. Is that shared by the people you're speaking with? And similarly, the Western European tradition of science and knowledge is starting to look at indigenous peoples around the world and the knowledge they have, and say things like, oh, maybe health and environment are linked. The World Health Organization said, protect and restore nature as the foundation of our health in a 2021 report for the upcoming climate change conference. Indigenous peoples around the world have known this for millennia, as have plenty of non-Indigenous people, of course. We might call these people wise. Now, here we're coming to a new word that we didn't define at the beginning, which is wisdom. There's knowledge, there's evidence, there's science, which is a form of knowledge. But remember, scientists used to be called natural philosophers, wisdom lovers. It might be possible to communicate knowledge and evidence, but wisdom? Is it something that occurs when you have the enabling conditions? Wisdom certainly doesn't come just from being rich, having a good education, and an internet connection. And I think anyone just needs to scroll through social media to have that confirmed. Arthur C. Clarke, in a report I read as part of some work for the World Health Organization on emergency risk communication, said, delivering credible early warnings to those who are most at risk is both an art and a science. It is an art and a science, but just because it's an art, it doesn't mean we can't have standardized ways of talking about that language. And I'll come to that in just a moment. Just before I do, I want to just quote this, which is to remind all of us when communicating to be cautious of cultural imperialism, sense of superiority. Ask yourself this question when communicating. Check your ego and your motives. You don't need to be an expert to understand other people's cultures or to understand your own and those power dynamics. And that's from an excellent book I'd recommend all of you to read, Sand Talk. A really great book. And I think really what I want to talk about now is if we say that communication needs to be two-way, what do we mean? We're creating evidence, and the first talk, Johanna was talking about the needs and identifying the needs. Well, how do we know what people's needs are if we don't ask them? And how do we know what people's research priorities are? And how do we communicate the results of creating this research and evaluating it? We've got 7 billion people and counting. How do we involve everyone in shaping this future? It's a lot of work and resources are limited. So I'm going to speak in just a moment about some evidence-informed ways of involving people and how we could do that. Just before I do, I want to summarize what I think are the 3 main challenges ahead of all of us. And I'm going to present these because I think it's important to acknowledge them. When this panel met to discuss this event, many of us agreed that the COVID pandemic had not revealed any new problems. It had just highlighted existing ones. The World Health Organization calls this an infodemic. Is this a reactionary buzzword? We've had 30 years to get used to the horizontal structure of the World Wide Web and to build upon that trusted layers of data. We've had even longer to challenge the bias of culturally induced ignorance. I want to know how governments and charities and commercial search engines and social media companies can work better to improve structured data and machine learning about trusted information so we can begin to automate these processes as per the previous talk. But how are we going to do that if we don't involve people? Knowledge is still power. A few years ago, I did some training for Cochrane where I talked about the story of Cochrane trying to get data about flu-inhibiting drugs, such as Tamiflu, for a systematic review. Data about human trials that hadn't been released. Governments have spent literally billions stockpiling this drug, and the Cochrane review concluded, after they got the data eventually, Tamiflu, and I quote, led to harmful effects that were not fully reported in the original publications, and that deliberate publication bias made Tamiflu look better than it really was. Reminder, the references for all of this are all available. I work on the health technology assessment process in Australia, and the only evidence governments consider is evidence from research that's often been paid for, of course. And sometimes the funder of this research is studies where the funder has a vested interest in the outcome. And in fact, there are Cochrane systematic reviews looking at this issue. We need greater transparency, not only about funding and conflict of interest, but for mapping areas which aren't being funded, including non-profitable diseases, as they're sometimes called, or diseases which affect predominantly people in poorer countries. Why aren't we researching these areas? Why is there that culturally induced ignorance? We also need to map the different interests that people have in research. Of course, they can be financial, but they can be personal. If you're affected by a rare disease, you have an interest in that research, or you might have a professional interest. Mapping different interests in a standardized and machine-readable way is something else that can be done with standardized data on initiatives or START-IT, and I'll talk about that at the end. And just, I want to sort of say something about accessing knowledge, because I work a lot with people affected by rare diseases, and I often get asked if they got any tips for accessing peer-reviewed information, because it's prohibitively expensive to pay for papers sometimes, to buy access to a paper. And I find myself saying that the only website in the world which offers free access to all peer-reviewed papers in the world is classed as illegal in many countries in 2021. We've had decades to fix our for-profit publishing industry. Closed access data and clinical trial results are not always being published. And you can look up the All Trials campaign if you want to learn more about this. Certainly data from historical trials about drugs we're still using. Is current paywall publishing in the spirit of the Declaration of Human Rights, the right to receive and impart information through any ideas or media? An open question to ponder. And just finally on the policy, is it left or right? This question asks, of course, who decides what gets researched and what doesn't? I've mentioned culturally induced ignorance, but who decides what gets researched and therefore what evidence we have? See the tobacco industry for an example of this, but there's so many areas where there are different interests in not researching certain things. On top of that, we've had UK formal inquiries saying that when we do go to all the trouble of making evidence and scientific advice, it's ignored. And in the Americas, we've had, at different points, presidents, plural, suggesting bleach as a treatment for COVID. We're in trouble as a species. We're in big trouble. The UN Secretary General said in a recent report by the International Panel on Climate Change, it was code red for humanity. I would say more accurately, it is code red for evidence-informed policy. How can we, as a species, bring evidence-informed policy into education, into dismantling information monopolies, and into collective decision-making methods? People need free access to reliable information, and we need to collectively agree how to build that, and we need to do that now. So how do we do that? And I'm wrapping up now. We need evidence-informed communications. Wikipedia is a fantastic source for multilingual information. Wikidata is one of the projects, and the wiki journals, which I'm involved with as a volunteer, are free to publish in open access and peer-reviewed. They're all an excellent source of information, but trust can be an issue. You know, who wrote this article? Can I trust this? At the moment, there's no standardized way to describe how people have been involved in creating communications, including research outputs, or to report the impacts of that communication. And certainly, Nice and Cochrane and Campbell all discuss the idea of measuring the impact of these communications. And the terminology is confused as well around people, evidence, data. These words mean different things in different languages. So what we've created is something called standardized data on initiatives to try and solve these issues. START-IT, for short, is an open access data sharing system to standardize the way that information about initiatives is reported, including which tasks were done by different people when creating the information source. You can create reports about systematic reviews, evidence synthesis, Wikipedia pages, anything, and anyone can create one at any point in multiple languages. And importantly, it uses structured data so that it can be machine readable, and it also aligns with existing reporting tools, for example, ones used to report the quality of systematic reviews. It's free to use, it can be submitted by anyone, and authors can be verified to improve trust and transparency. And I think trust underpins human civilization, doesn't it? If we don't have it, we're in trouble. So really, it's just an invitation to learn more about START-IT and what we're doing. There's a link just at the bottom there. And I invite all of you to ponder on these questions now as I finish. So we're going to do a poll. I'm interested, where do you go first for trusted information? So, assuming you might start at a search engine, where next? And I think just while you're pondering this question, when does data become evidence, I think, is an open and ongoing discussion that needs to involve everybody. And I think I'd be very interested to hear some thoughts on that. And I'd love to hear any thoughts or ideas about Start It. Anyone who knows me well knows I don't need convincing to talk about it, but I'd love to hear any thoughts or feedback. And my final thought, I'm going to quote the late Hans Rosling in his book, Factfulness, which is a great read. He said, ask yourself, what kinds of evidence would convince me to change my mind? So I'm going to finish there. And I think maybe we'll get the poll results after Zach has asked me some searching questions. But thank you for your attention. That's me.
Fantastic. Thank you, Jack. Some really, really big issues that obviously need to be tackled. And thank you for raising these challenges and highlighting some of these issues. I hope we have some time in the panel discussion to unpick all of these. And I loved the talking about needing evidence-informed ways of communicating as well, which is just so important and sometimes overlooked, unfortunately. There have been some questions that have come in for you, Jack. So I might ask you, this one's come in from Carolyn Wood. And she's asking, how can we encourage people to search for the truth on a topic rather than just search to find information that confirms what they already believe to be true?
That's a fantastic question. And suddenly we're into the domain of psychiatrists, psychologists, neurobiologists, sociologists, social, all those disciplines that often don't get treated as, hard science are suddenly probably the most important. And you know what? This is my personal opinion. It needs to start with education, evidence-informed education, teaching people how to ask a question, can I trust this? And teaching people the basic skills of critical appraisal, which in plain language is, who wrote this and can I trust them? That's the foundation of all human society. Says who? And what's the motto of the Royal Society? On no one's word. But sometimes we have to take people's words on trust. And I would say education. But this is a problem that our species is wrestling with. And if we don't solve it, we're going to take a lot of other species down with us very soon. Or a lot more, I should say.
Do you have any reflections on what seems to be the growing distrust in expertise and experts and science in general?
Yes, I would say the language we use is muddled, and that's why I started with an expert is in the eye of the beholder. We get to decide who we think an expert is. I will say that I think commercial search engines and commercial social media companies could do a lot better at highlighting, let's say, the voices of those people who we collectively agree we can trust, experts. But even that in itself is a difficult thing to solve. And I think, that's why we need this transparency and machine readable data to describe, who is this person, who's funding them. A couple of people started their presentations saying no interest to declare. That's not true all the time in life. People don't declare that. Sometimes people are trying to hoodwink you. And it's really tough. So I would say as a concrete action, Cochrane, Campbell need to work with governments around the world to come up with standardized machine readable data that can be used by search engines and social media in their algorithms to highlight information that is good quality and trustworthy. But we need to act fast.
Fantastic, great reflections. Now we've got a lot of people who have completed this poll, so I'm just going to share those results, Jack. And before we head over to our last speaker, was there any reflections you wanted to make based on these results?
Good on the World Health Organization. Let's give it some more money. And also, finally, Wikipedia. I will advocate that it's one of the most trusted places you can go for public information. There's a lot of papers on how well up to date it was through a huge volunteer effort. And that is quite transparent about who got information sources from where. But we can improve that. And so you can definitely use standardized data initiatives. We're working with the Wikimedia Foundation to try and hard bake that into things like Wikipedia, and I've just shared a link to that in the chat. I will finish now. Thank you, Zach.
Fantastic. Thank you, Jack. Great presentation. Okay. And our final formal presentation today to tell us all about how we can leverage intermediaries, I'm struggling with that word tonight, in the infodemic is Dr. Nasreen Jessani. And Nasreen is a senior researcher at the Centre for Evidence-Based Healthcare in South Africa. And Nasreen is responsible for capacity strengthening in evidence-based information decision-making and knowledge translation. Her focus is on the nexus between health policy and systems research, innovations in evidence-informed policy and practice, and the relationship between academia and public policy. Thank you, Nasreen, for joining us, and you can start your presentation.
Thank you, everyone. I hope I'm sharing the right screen. Just let me know if all is well, Zach.
All good.
Excellent. Great. So the title of my presentation is slightly different from what Zach presented, but it follows the same thought. And I'm going to speak to you a little bit about the power and the perils of knowledge brokers in pandemic communication. And part of this is based a little bit on inspiration from my previous colleagues that spoke previously. One on by Johanna in terms of typology of user, and I think different kinds of actors in this ecosystem of communication are accessing information for different reasons and in different ways. But then this also moves to the trust aspect that Jack was talking about in terms of, well, who do you get your information from? So I was a little bit struck by the Hans Rosling quote on what kind of evidence would convince me. And I think some of this is not about what kind of evidence, but who is sharing the evidence and how will that convince me. And I think as we go through this presentation, maybe some of this will be relatable. So just a quick introduction on what is a knowledge broker. So once again, using Wikipedia here, a knowledge broker is defined as an intermediary or either an organization or a person that aims to develop relationships and networks with, among, and between producers and users of knowledge by providing linkages, knowledge sources, and in some cases, knowledge itself to the network. The key feature of a knowledge broker or an intermediary is the facilitation of knowledge exchange or sharing between and among various stakeholders, including researchers, practitioners, and policymakers, but also the public. And in the field of public health, which is the field that I work in and where my bias comes from a little bit, is we often refer to knowledge brokers as bridges, intermediaries that really do link evidence to policy. And so I want to speak a little bit about the power of influencers and intermediaries. Zach, you're not the only one having trouble with that word. And the dangers as well as the missed opportunities. So I'll give you some examples here. We have several celebrities internationally, locally, and in our own context that have ended up using their celebrity status and their massive following to influence responses to the pandemic. We've seen them use these productively, like on this tweet from Mandy Moore on staying home to protect healthcare workers and the strain on the health systems. And also for those of you who know Lauren Gray, asking other celebrities to stop having parties. This was during lockdowns. But then we've also seen other celebrities using the same power and the same influence to spread misinformation and disinformation. And so it's important for us to think about them as really important actors in the ecosystem where trust has been built, or that they have influence for different reasons in terms of their followings, but in terms of science communication have played a very strong role over the last definitely year and a half. But if we go back decades, we've seen the role that celebrities play. Here in South Africa, where I'm based, one of the provinces also capitalized on this potential and enlisted a local influencer as a means to encourage more people to come forward with their vaccinations. And if you look at the clip here, it is a medical doctor and a model who they chose to be their vaccine influencers, and particularly to encourage young people. So it was a strategy that was recognized and leveraged right away. And we've seen different strategies across our different provinces here in South Africa. So this is one that was really interesting to highlight. I think there's been also a recognition that we, unfortunately, for a long time, didn't recognize or realize the role and the ability for us to leverage faith-based and community leaders. And in April 2020, WHO and UNICEF joined forces to announce the Multi-Religious Faith in Action initiative to raise awareness of the impact of the pandemic on citizens. And this was in recognition of the powerful role of faith-based community and religious leaders. And though many places of worship were closed during the pandemic, we know that faith-based and community and religious leaders continued to be a trusted source of information and support and mentorship. They played a vital role in keeping communities united through uncertain and sometimes very fearful times, the whole pandemic, especially in the beginning when there was very little known about what this means for us as humanity. Most people turned to faith or their religious leaders. And so they also pivoted to social media. They did sermons by Zoom, prayers by WhatsApp, and contextualizing the pandemic to languages and cultures they oversaw. Because as you know, most of the information we're consuming is in the English language, and the censorship that has now come from YouTube and Facebook has been on misinformation, but really only on the English language. So how are we combating this in other languages that are not recognized by mainstream social media? And we're finding that they've got a very strong role to play. And so in Africa, we saw this recognition in the African newspapers, even though we note that this was recorded locally. You'll see here also in Indonesia in the cartoon clip at the bottom. But as countries allowed religious reasons for vaccine exemptions, it's interesting that this article in Forbes magazine notes that religious leaders have actually been more supportive of the vaccines and have tried, at least in many cases, not to politicize it and nor to use religion as a convenient excuse. So I think we didn't see this important voice appearing very often in decision-making or even in implementation. If we look at many of the decision-making bodies, the expert committees, well, there have been many criticisms, but one of the main criticisms has been there hasn't been a diversity of voices. And we haven't really looked at the role of various actors, the power that they have in play on local communities, and how best that they can be leveraged. And so I think it's important to know this and also to see, well, then how do we engage with these kind of organizations and communities? And at Stellenbosch University, at the Center for Evidence-Based Healthcare, we work very closely actually with the media, particularly with the Center for Health Journalism called BEKISISA. And mainstream media became this important intermediary as well. And ensuring that science was informing the headlines really became critical. So there were two programs that we launched. One is the one that you see on the screen here, which is to train Africa-based journalists in epidemiology, and really to better understand the science that's informing these headlines that we all read in the newspapers. It was attended by 63 journalists across 18 different African countries. And it led to, and has led to much more nuanced and informed reporting style, as well as greater demand for scientific information before reporting is occurring. So the course included information on what is evidence? What are systematic reviews? Where do you find information? How do you appraise it? Who do you go to? How do you find the experts? What journals are credible? And so it was a crash course in epidemiology, but we found that it actually has really helped with the dispelling of myths and also gaining trust of the public. Another course that was held was on vaccine science for journalists. And as you can see here, a little tongue-in-cheek pun, it was a necessary shot in the arm for journalists, but it really has been very helpful to be working closely with mainstream media. So I'll just kind of summarize in terms of our reflections as we've been battling the infodemic, at least here in South Africa and in many places on the continent, is that it's really important to recognize the wider actor ecosystem in terms of who do people trust for their information and how do we equip them with trustworthy and credible information and evidence for them to be able to communicate it as messengers. And this is important to do over time to build, nurture, and maintain relationships. We found that it was easy to leverage these relationships if they'd already been built, but we will continue to nurture them over the next few years in the event that we can continue to ensure the communication of trustworthy relationships and trustworthy information. Key trusted intermediaries are important to leverage, but we have to engage with them authentically and mutually enhance bi-directional understanding and capacity. We also learned a lot from our media colleagues, so this wasn't just a one-way training. And it has fostered a lot of trust and a lot of respect. And we've learned along the way because we've kept a pulse on our activities, we've monitored the outcomes, and then we've adapted along the way. And so it's important for us to consult with civil society to address and try to provide answers to the questions that are important to the general public. And hopefully this will spur more discussion. Thanks, Zach, back to you.
Fantastic. Thank you, Nasreen. What a really interesting presentation. And I love that at the start when you talked about it's not just what the evidence is, but who is sharing the evidence. And I think you really touched on a lot of key points during your presentation with some really great and interesting examples. And those courses that you do for the journalists and the media, they're fantastic. I was wondering, how did the journalists receive the course and the course content, and were they shocked or surprised, or how did they receive it?
So I think, I mean, most of this was done over Zoom. So part of it was who had access to the internet for the training, but so that's also a challenge that obviously everyone is facing and has faced. But in terms, I think there was just a real, it was like, they were all like sponges in many ways. There were loads of questions, but also an appreciation for science and the scientific process. And the complexity of science. I know we talk about the art and science of communication, but there's a real complexity in it as well. And we also at the center teach courses on evidence-informed decision-making, how to engage with the media and how to engage with decision makers. And we always touch upon, the art, science, and complexity of all of this. And so I'm not sure, to be honest, Zach, how often we're going to be offering these kind of courses, but given that part of it has to now be some reflections from journalists about how they've been able to utilize their learnings in their reporting and in their understanding and knowledge is something that we're also really keen to learn about. But we did partner with colleagues in other universities overseas as well, but very much localized the content to our context.
Yeah, fantastic. And what a great way to combat misinformation. So thank you so much for sharing that, Nasreen. I think we could keep unpicking that for a long time, but we better get into our panel discussion, as I know there are a few questions in the Q&A that we want to get into. But what I'd like to do is ask all of our panel members to turn their videos on as we get into our roundtable discussion on some of these issues after those fantastic presentations. And firstly, I'd like to introduce Jane Cowell and Jenny Whale, who you haven't heard from yet today, but will also be joining our panel discussion. And Jani has a PhD in pharmacology, but is active as a patient and consumer advocate since 2000. And providing consumer perspectives to and developing plain language summaries of Cochrane reviews across many areas of healthcare, and is a consumer advocate. And Jane Cowell is a senior public involvement advisor at NICE in the UK and leads a team that supports patient and public involvement in developing and implementing NICE guidelines. Jane is also the chair of the Guidelines International Network Public Working Group and has led the update of the recently released and very fantastic resource, the GIN Public Toolkit. And I might start off by just asking you a question, Jane, if that's all right. So I was wondering, what do you see as the barriers to involving patients and consumers or the public in actual evidence generation, as this might be a way to help combat misinformation as well? How can we do this? What are your thoughts on this?
Thanks, Zach. Well, the barriers and solutions are in a way two sides of the same coin, if you like. In terms of guideline development, studies have highlighted several barriers. One very important one is guideline developers not having a clear recruitment strategy. So in other words, not really knowing who they should be involving, how many people, in order to get genuine representation and have a breadth of perspectives. There are planning and resources issues. There are also barriers in terms of people not feeling supported and it not being set up in the right way. So, for example, people feeling that they're not equal in the situation with other people they're working with the researchers and healthcare professionals. People not feeling clear about their role, or not indeed having the skills or knowledge to contribute. So the flip side of that is that there are solutions to this, and with careful planning involving people from the start, with good support and training, and that includes co-learning. Learning together is really important. I think that's been brought up by other speakers about how we learn from each other. This is not a one-way process. Healthcare professionals, researchers will learn a lot from people with lived experience, consumers and members of the public. And it's really important that people get feedback on their contribution, and that if working in a group, or whether that's virtual or in person, that group dynamics are well managed. And we've seen a lot about how important it is to have a great facilitator or chair who is skilled and trained in running an inclusive group. So there's some of the things. In terms of COVID, clearly one of the big barriers has been the speed at which the work has to be conducted. So, for example, with rapid guidelines, there's a big barrier. In my own organisation at NICE, rapid guidelines had to be turned around in a week or two. And so initially, at the start of pandemic, when this was the case, it was a real emergency. We had to get the guidelines out as quickly as possible. We started off by engaging patient organisations rather than recruiting individuals, because the timescale didn't allow us to recruit and support people in a timely way. That changed over time as the timescales got a bit easier. And for example, for a rapid guideline on long COVID, we were able to recruit and support people with lived experience of long COVID, and they took part throughout the process. I will stop because I'm sure there are lots of other important questions.
No, that's fantastic. Thank you, Jane. That's a really good overview and a really good discussion about how we can actually include patients and the public in our guidelines and generation of evidence as well. There's often a steep learning curve for people who are going to be involved in these projects as they learn about the evidence and everything else. And we've also talked, Jack actually mentioned health literacy earlier, and perhaps some issues with this term. And Jani, as a consumer advocate, I wonder, do you have any thoughts about health literacy of the patients and public this term, and how we could improve health literacy despite it perhaps being a difficult term.
Yeah, I'd like to go back to what Nasreen said, that in terms of religious leaders and also journalists, that we actually have to learn to trust the community, and that this is a mutual thing, that it's not just that the consumer needs to understand what the healthcare provider is saying, that the healthcare provider needs to understand what the consumer is saying. And so we need to get our messaging clear, and it needs to be logical. And we need to also provide clear information and be clear about the uncertainties in the information, and not pretend that we're all experts, because each is expert in their own way. So we need to come together and actually not just address what a researcher decides is important to research, but to look at what matters to the public and to patients and address those, so that it's a true communicative process. And so, and in this, we can then empower or give the community, make them more self-efficacious, give them something to do, so that you're contributing rather than, oh, here, you can do this little bit while we do all this really important stuff. And so I want to talk about the term democratizing evidence. How about we democratize evidence? Can you add that to your list, please, Zach?
For sure.
Jo pointed out how there were many systematic reviews and obviously, and studies, and infodemic, but obviously the people weren't doing this just for the common good or to improve health outcomes, because they weren't well done. So we really need to get back to the root of this, and who is managing the researchers in a way. So if you democratize, for example, evidence, and start reporting more, for example, on patient-reported outcomes and patient-reported experience measures, and consider that as an important part of the evidence, then you're empowering the whole community, not just one half of the community. I'll get off my high horse.
Thank you, Jenny. They're fantastic reflections, and thank you for sharing those. I'm just going to go to the Q&A now, and there's a question from Carolyn Wood, which asks, as the world becomes more digital, what new ways of communicating health information may become more dominant but are not widely used yet? And Nasreen, I might turn to you, because you touched on TikTok and sometimes the role of influencers. Do you have any thoughts on this question from Carolyn?
I think it's an interesting question, because the world is moving more digitally, but for some, not for all. It's still access to the internet is difficult for many in our countries, in all countries, even high-income countries. There are areas and regions and communities that just don't have good access, or where data is just really, really expensive. So the access, physical access is there, but financial access isn't. And so I suspect that we will still in many ways depend on trusted leaders. I think some communities will continue to use drama, word of mouth, sermons, community meetings, to be able to share songs, poems, to be able to share. Here in South Africa with the youth, they come up with some great songs and dances to be able to speak to the youth about the importance of vaccine hesitancy, or just vaccines to overcome hesitancy, so that they hear from people that look like them, understand them, and it's not just government communication. So I think we'll have to see how digital we're going and how that changes, but I think we will always rely on the word of trusted colleagues around us, whoever that may be, and how best they prefer to communicate. Yeah, I don't know if anyone else wants to jump in.
Yeah, does anyone else have one? Jack, would you like to mention something on that topic?
Yeah, I mean, I think that's a great point, isn't it? I mean, we run events called Campfires in Science that you get people around a campfire to share knowledge, and all of our ancestors have been doing that for millennia. We've not been able to do it during the pandemic, and I'm glad I'm alive in an age where we have this wonderful information technology. I think the question asked to us was one of the future. I would summarize my answer with the word accountability. At the moment, search engines, commercial search engines, social media companies are utterly unaccountable for the content they promote and share. It's, you know, and so frankly, are most of the media organizations, without highlighting any particular ones, I'm sure you know what I'm talking about. They say stuff that's not true and nothing happens. How do we fix that? I don't know. Let's ask some lawyers, some class action lawsuits might sort it out. But I think us, community of evidence creators, need to just stay in the background. And I don't think it's realistic to fight every fire. I think we need standardized, systematic ways to work with big tech companies, social media companies, with governments to get the information people need in front of them so they don't have to think about it. It's a fundamental principle of web design. There's a book called Don't Make Me Think. And I think it's an interesting moral question, isn't it? Who's morally responsible for making sure people see information that can be trusted? And, you know, we've all been in a health emergency. Maybe we put something into a search engine if our pet's eaten something or our kid isn't well. You know, you want that information quickly. You're not going to go, hang on, I'm just going to critically appraise this systematic review and, you know, the forager approach of Johanna. We need instant and emergency information right at the top that we need to know it's trusted. You know, I've eaten this mushroom. Am I going to die? Yeah. And we need to sort that out right now. And I would say Wikipedia needs to be a big part of the answer to that. I'll finish. Thank you.
No, that's great. Thank you, Jack. Really good reflections. Thank you, Nasreen, as well. I'm going to go to a question from Rachel in Brussels. She's asked, do you see vaccine hesitancy as an example of how experts have failed to communicate risk and benefit around COVID and other vaccines? So obviously we know the importance of vaccines. We have the scientific evidence to improve how useful they are in combating COVID, yet we still see vaccine hesitancy. And I wonder if anyone has any reflections on this. And it kind of links back to some of that element of trust that we've talked about earlier as well. Jani, would you like to mention something?
Rachel also puts another question at the end, how all the different experts disagree, and also that together with the willingness of people and journalists to jump onto the latest news without thinking of the whole picture and where we're going has been a real problem with vaccine hesitancy, that particularly in Australia, where we all knew what the problems with issue in Australia. So of course people started off being very hesitant. So I agree, we need more cooperation at a high level, be it COVID and plus a number of related groups that synthesize different types of evidence, whether it be WHO. I think we need those accountable organizations.
Yeah, and I think it's a really good example here of where things have changed and recommendations have changed regarding vaccines, and different authorities have had different opinions as well. And I think about in Australia, the AstraZeneca vaccine, and how different chief health officers have had different recommendations, and sometimes this conflict is hard to communicate, I guess, to the public. And I guess it all gets around to firstly contextualizing evidence, but also recognizing that there is sometimes we don't always have really high levels of certainty in the evidence, and how we might need to sometimes communicate that uncertainty and that things can change. And that's happened a lot in this pandemic. I wonder Jo, perhaps from a systematic review perspective, or maybe Johanna from a guideline development perspective, what do you think the answer is when evidence changes, or we're trying to make decisions on low certainty evidence? How can we get these messages across that sometimes evidence does change and science does change, but it doesn't mean we should stop trusting it? Johanna?
I think one of the findings from our work has been that we have a tendency as guideline developers to only put the information that people want to see, and actually where there are gaps in the evidence, where there's uncertainty, we're not very good at including that in guideline recommendations, for example. So we won't say we've looked for this evidence, but actually we couldn't come to a conclusion. We tend to only put where there's a positive recommendation or where there's a kind of uncertain recommendation based on consensus. So I do think we need to get better about that as well, because then when things do change, it gives us the opportunity to challenge it and say, actually, we've now got more evidence. We know that we've got the quality there, and this is what we now recommend.
Yeah, fantastic. And trying to prepare people, I guess, to let them know, right, that things may change in the future as more evidence comes up. Jo, you've kind of touched on this regarding findings from systematic reviews, and some are trustworthy and some maybe not. I wonder if you have any reflections on that previous conversation, or if you might have an answer for Lumna, who asked about the proportion of reviews being organised and funded by professional organisations.
Yes, so I mean, in relation to uncertainty, I think we don't really know how to do that. So I think it's an area that we need to work on. I think systematic reviews have a bit of a reputation for ending with more research is needed, which, you know, people would just laugh and say, why would I bother to have read that then? So, you know, obviously that's not the answer, but we do need to think about how we could do that better. In terms of how many of the reviews within our meta-research study were Cochrane or professional organisations, I don't have the number off the top of my head, but it wasn't very many. Yes, I mean, yeah, there weren't very many, but I think that it shows that we need to look sometimes, I think, within the professional organisations, we believe that we're the only ones doing this, and actually we're actually a minority, and the work that perhaps Cochrane, Campbell, JBI are doing is actually swamped by the work that other people are doing. So we maybe need to find ways of making it more clearer when this is more trustworthy evidence.
Yeah. Thank you, Jo. And Jack, there's something you'd like to add?
Yes, thank you. I think we need to be really clear when we're communicating with people, when we say there's no evidence. If I say there's no evidence of gender inequity in Australia, you could say, well, what research have you done? And I say, well, I haven't done any. That's why there's no evidence. And there's actually culturally induced ignorance here, sometimes from an ideological basis. Sometimes we say there's no evidence, like, for example, homeopathy, and we go, we've got loads of data. It's a placebo effect. We're pretty sure. We're pretty as sure as you can be. So that's the first thing. When we say no evidence, is it because there's no data or because we've done no research? If we haven't done any research, as Jo said, why not? I mean, you know, I work in the health technology assessment process, and there's so many rare diseases or rare cancers or what have you, where the evidence thresholds required by health technology assessment processes means there will never be enough evidence or data to the standards required. And sometimes I'm asking myself, well, why doesn't someone just do some more research on this? And I think I'd like to see Cochrane and other organizations connect better with research prioritization and funding processes when there are gaps in the data to fill them and not just go, oh, well. So yeah, anyway, I'm probably getting a bit worked up, so I'll leave it there.
No, it's fantastic, and I love your passion, Jack, and really important points. Jane, I wonder, just going on from Jack's points about prioritisation and research, do you have any reflections from your role of public involvement?
Well, I was just, as Jack was speaking, I was just thinking of the James Lind Alliance, and that's a good example of people with lived experience of a condition working with healthcare professionals, working with researchers to identify what the most important research priorities are. So again, it reflects the theme that's come up all through this webinar about make sure you involve the people for whom this research potentially could be relevant, you know, involve people with the condition or with the interests in the community and find out what needs to be researched. And I would completely endorse the points that have been made about we need to challenge what isn't getting researched. And also there's a lot of duplication of research. I mean, there's a lot of waste going on that we need to eliminate because it's a waste of everyone's time and money. We need to make sure that the right things are getting researched, and that's difficult because of all the issues that Jack raised in his presentation.
Well, yes, and remembering, as Ian Chalmers and Paul Glazier often say, these are trials that people have participated in, patients who have participated in, and that trial data is not being published, not always. You know, why? Why? We need to fix this.
You could argue it's unethical, couldn't you, Jack? And thank you, Jane, for those reflections. And I'm reminded of the old adage, you know, no research for me or on me without me. Which I think is a really important point to keep at the forefront of engagement. I've been a terrible chair because we have gone over time, but the discussion has just been so wonderful. I couldn't bring us to a close. There is just one last question that I think might be useful to answer, and it's for you, Nasreen. It's from Jodie Boffer, and they're asking about commenting on how fantastic the EPI course for media was. And if you were going to do it again, how would you try to reach some really influential radio stations or try to get into rural and remote communities? What's your reflections on this question?
No, I think that's a really great question. And Jodie, would be, if we had time, it would be great to hear your perspective from having attended the course or having facilitated the course, since you know it well. I think it would be great for this kind of training to actually get mainstreamed into trainings of, you know, journalism and science communication, so that individual organizations like ours don't have to do these kind of workshops that are one-off, and that it just becomes part of how journalists report, is that they question their sources, they protect their sources, they know where to look for it. So that would be more like, I think, more of a sustainable way for the training of journalists, and they would get this training in the languages that make sense for them, but in the mediums that also make sense, because radio reporting is very different from TV reporting, which is, you know, and all of them have different strategies and different strengths and different ways. And most of our rural communities are receiving their information from a variety of radio sources. Similar to other countries, some of these are politicized. And so people tune in to radio stations that kind of fit their own beliefs or their own political ideologies. And that can sometimes create more misinformation. So it's a tricky one, but I do think that if this was something that, if this has been the pilot case for training of journalists, then I think there is a really good argument for speaking to schools of journalism globally about the importance of kind of embedding this kind of component into it, the understanding of science, and that would assist them in the reporting across sectors, not just health, whether it's talking about agriculture, education. Jack was talking about just general like evidence-informed policy, no matter what the policy. And so no immediate solutions except for these one-off workshops, but I do think that we need to think of something more long-term and sustainable. Thanks.
Fantastic. Thank you, Nasreen. And that sounds like a wonderful idea. If we could try to get this training embedded in all journalism courses, that could make a huge change to some of these issues we see with misinformation and what we've seen in the infodemic. So I want to say a big thank you to everyone who's been involved with the session today. Unfortunately, we have come to the end, but a big reminder as well that We are just kicking off World Evidence-Based Healthcare Day today, and the next 48 hours or so are going to be a lot of fun. There's over 30 or more virtual events that are going on, and I'd recommend you all to take a look at the World Evidence-Based Healthcare Day website and keep an eye on your Twitter feed as well and social media outlets to see what's going on and get engaged, because that's what World Evidence-Based Healthcare Day is all about getting engaged, sharing your experiences, sharing your stories, and learning from each other as well, and shining a spotlight on the importance of evidence-based healthcare. One thing you can also do is head to the website and read some of the blogs about the global evidence community's experience of infodemic management. And this is another way that we can learn from one another during these challenging circumstances. And there's over 40 of these blogs now available on the website. So please, when you get a chance, please do check it out. Okay. And so once again, a huge thank you to all of our panelists today, and a huge thank you to all of our attendees as well, and everyone who's given up their time today. I hope you will agree that it's been a fantastic session, and we've hopefully all learned a lot. And just a reminder, you'll be able to revisit this session as well, because it has been recorded and will be online and hopefully disseminated widely in the future. I do want to make a special thank you not only to our wonderful panelists, but also to the team here at JBI, the communications team, who have really bent over backwards to get this day up and running for this event. And a particular thank you to Bianca Pillar, our Director for Global Relations, who has not only organised this event whilst being in the background, but is in actual fact the person who brought World Evidence-Based Healthcare Day into the world, and really has championed this day and led it to be successful. So a really remarkable achievement and quite a legacy. So thank you, Bianca, for all your hard work. Anyway, I'll let you all get on with your day. We've already gone over time. I hope you've enjoyed it. It's been an absolute pleasure to kickstart the festivities with you all today. And I wish you all the best and a happy World Evidence-Based Healthcare Day, and look forward to seeing and interacting with many of you over the next 48 hours or so. Thank you again, everyone, for joining us today.
Thanks, everybody.
Bye.